Welcome to ED Debrief, where data meets the gurney. Today we're stepping right into the resuscitation bay.
We really are. And it's a stressful one.
Yeah, we're tackling a scenario that makes even veteran emergency physicians sweat. We're doing a deep dive on Chapter 298, the patient with morbid obesity.
Right. And we should clarify up front, this isn't just general health advice for you today.
No, not at all.
We are looking at this strictly through the lens of a high-stakes tactical review. This is for the PBEM exam, the Philippine Board of Emergency Medicine.
Which means we're talking about geometry, we're talking about physics.
Exactly. And the very specific physiological adjustments you have to make to save a patient's life when the standard playbook completely fails you.
Because it will fail. I mean, looking at the source material, obesity rates have doubled worldwide since 1980. So you're seeing this in the ED every single day.
Every shift. And if you treat a 150-kilogram patient with the exact same heuristics you use for a 70-kilogram patient, you're setting yourself up for a disaster.
The text describes it almost like dealing with a completely different physiological state. It's not just, a heavy patient.
Right, it's a distinct physiology. The baseline reserve, the response to trauma, the way they metabolize drugs. It's all altered.
So our mission today is to give you that PBM edge. We're going to break this down into four main areas. First, the silent killers and diagnostic traps. Then the logistics of just, getting basic vitals.
Which is much harder than it sounds.
Way harder. Then we'll hit the math. The dosing minefield, where most of the critical errors happen.
And finally, the airway, the most dangerous few minutes in emergency medicine.
Let's jump right into the silent killers. Part 1. The text highlights this concept called the masking effect.
Yeah, this is a classic board trap. The obesity itself either hides the underlying pathology or it completely mimics it.
The classic example they give is the patient who comes in short of breath, right? They've got leg swelling.
Yep. You walk into the room, the patient has dyspnea, they complain they can't lie flat, so orthopnea, and you see massive edema in the lower extremities.
And as a resident, your pattern recognition just screams congestive heart failure.
Instantly. You're reaching for the diuretics. You're calling cardiology.
That's right.
But in a patient with morbid obesity, severe physical deconditioning alone creates that exact same clinical picture.
Because just the physical effort required to move that much mass creates the dyspnea.
Precisely. And the venous stasis from the abdominal pannus compressing the groin veins, that creates the pedal edema. It's a perfect mimic.
Okay, but normally you just run a tiebreaker. You order a BNP, brain natriuretic peptide.
Right, the gold standard for heart failure.
If the heart is stretching, BNP goes up. But the text drops a massive bombshell here.
You cannot trust a normal BNP in these patients.
Which is wild. Why is that? Is the heart just not releasing it?
Oh, the heart is screaming for help. It's releasing the BNP, but the adipose tissue is eating it.
It's eating it.
Yeah. Adipose tissue is biologically active. It expresses very high levels of clearance receptors, specifically the NPRC receptor. Right. And these receptors bind to the natriuretic peptides and clear them out of the blood before your lab test can even measure them.
So you could have a patient in active florid heart failure.
And the lab result comes back totally normal.
Yeah.
Because the fat muffled the signal.
If you trust that number, you discharge a patient who's going to crash.
Exactly. You have to rely on clinical gestalt. You have to use bedside ultrasound. Do not let a normal BNP reassure you in a morbidly obese patient.
That is such a high-yield pearl. So moving to the respiratory side, the text dives into obesity hypoventilation syndrome.
It's OHS.
The Pickwickian physiology.
Right, from the Dickens character. But clinically, what are we actually looking at here?
You're looking at a patient who has completely lost their physiological reserve. It's a deadly combination of daytime hypercapnia, so retaining CO2, and severe hypoxemia.
And they're retaining that CO2 because the sheer weight on the chest wall makes it physically impossible to take a deep enough breath to blow it off.
Exactly. It functions as a severe restrictive lung disease. And they usually have pulmonary hypertension on top of it. The text used a great analogy for this lack of reserve.
Right. Think of a healthy person as driving a car at 40 miles per hour. If they hit a pothole like a mild pneumonia or they get a little bit of sedation, they swerve, correct, and keep driving.
They have a buffer.
Right. But the patient with OHS, they are driving that exact same car at 100 miles per hour. They are redlining the engine just to sit upright in the bed.
Wow.
So if they hit that exact same pothole, they crash immediately, there is zero buffer, they desaturate incredibly fast.
Which perfectly sets up the urgency. The physiology is constantly working against us. So let's talk about the logistics. Part 2, getting the evidence.
This is where basic medicine becomes a physics problem.
Right. You walk in, you want to do the simplest thing in the world, take a blood pressure, and apparently we're all doing it wrong.
Most of the time, yes. Standard blood pressure cuffs are designed for an arm circumference of up to about 32 centimeters. If you wrap that standard cuff around an arm that's 40 or 50 centimeters, the machine has to exert vastly more pressure just to compress the soft tissue enough to reach the artery.
So the monitor interprets that extra squeezing effort as high blood pressure.
Yes. You get pseudohypertension. You get a reading of 160 over 100 when their actual intra-arterial pressure is 120 over 80.
That's a huge difference. You might start pushing antihypertensives on a normal patient?
Or much worse, you might miss a patient who is in active shock because their falsely elevated reading looks normal on the monitor.
So what's the fix? Because the text says it's not just about grabbing the large adult cuff.
It's strictly about the bladder width. The inflatable bladder width must be 40% of the arm circumference.
So let's give the numbers for the listeners.
For a 35 to 44 centimeter arm, you need a 16 centimeter bladder width. For a 45 to 52 centimeter arm, you need a 20 centimeter width.
And if you don't have that exact size,
Do not guess, place it on the forearm, or if they are critically ill, drop an arterial line. Garbage in, garbage out.
speaking of garbage data, let's talk about getting a weight. We need accurate weights for dosing.
Which we'll get into.
Yeah, but physically getting a 150 kilogram patient onto an ED scale is sometimes just impossible.
And asking them is useless. Patients consistently underestimate their weight.
And we're terrible at guessing, right?
Oh, doctors are awful at it. The source cites a study showing clinicians miss the actual weight by an average of 20 to 30%.
And in pediatrics, this blew my mind, the Broslow tape. I mean, that was the gospel for pediatric codes.
It's failing us. The Broslow tape correlates patient length to weight. But with the massive rise in childhood obesity, that tape now underestimates weight in about 1/3 of pediatric patients.
So you're underdosing epinephrine in a code.
Exactly. It's terrifying.
So for adults, if we can't get them on a scale, what is the PBM next best step?
You use the Crandall formula. It's a calculation based on arm circumference and height. It requires a bit of math, but it is vastly more accurate than just eyeballing someone from the foot of the bed.
We'll make sure to put the Crandall formula in the show notes for you to review. Let's move to imaging. The text calls these the blur and the crush.
Right. The blur is attenuation. Fat tissue absorbs X-ray beams. So a portable chest X-ray on a morbidly obese patient is frequently non-diagnostic.
It just looks like a gray fog.
Yeah. To fix it, the tech has to increase the exposure time, but taking longer introduces motion artifact because the patient is breathing or shifting, so it's still blurry.
And crush, that's about the physical limits of the machines.
Table weight limits and aperture limits. CT scanners are getting better. Newer ones can handle up to 660 pounds.
But MRI is still restrictive.
Very. MRI tables often cap out around 300 to 350 pounds. But even if the table holds them, you have the aperture limit, the donut hole.
Right, if their shoulder-to-shoulder width is wider than the bore.
They physically will not fit. You need to know your specific department's hardware limits before you transport an unstable patient down the hall, only to have to wheel them back.
Okay, let's slow down here, because part 3 is the management, and specifically the pharmacology. This is the dosing minefield. This is the high-yield fact sheet for the boards.
This is absolutely where the most lethal errors happen.
The core dilemma you face is, do I dose based on total body weight, TBW, what they actually weigh, or ideal body weight, IBW, what they should weigh for their height?
And if you guess wrong, you either overdose them into toxicity or you underdose them into clinical failure.
And the guiding principle here is solubility.
Yes. Is the drug hydrophilic, water-loving, or is it lipophilic, fat-loving?
So let's run the board scenarios. You are preparing to intubate. You need paralytics, succinylcholine, and rocuronium.
These are your absolute must-knows. Succinylcholine and rocuronium are water-soluble. But because a morbidly obese patient has an increased total blood volume and increased muscle mass to carry that weight, you must dose these based on total body weight.
I want to make sure you hear this clearly. If I have a 150 kilo patient and I dose rocuronium based on an ideal body weight of 70 kilos, what happens?
You severely underdose them, the patient will not be fully paralyzed.
And when you go in with the blade?
They gag, they vomit, they aspirate, or you trigger a massive laryngospasm. It is a catastrophic airway failure. You have to use their actual total weight for paralytics.
Sucks and rock equal total body weight. Got it. Now, what about the induction agent, propofol?
Propofol is highly lipophilic. It loves fat, but its hemodynamics are very tricky. If you push a massive bolus of propofol based on total body weight, like 300 milligrams for that 150-kilo patient,
You're going to crash them?
you will cause profound vasodilation and direct myocardial depression. You will bottom out their blood pressure instantly.
So for propofol, we pull back.
Yes. Dose propofol based on ideal body weight. You can always push a little more if they aren't completely under, but you cannot unpush it once their MAP drops to 40.
Propofol equals ideal body weight. Now let's talk post-intubation sedation. Fentanyl and midazolam.
Also highly lipophilic. They love the fat sponge.
Right, the sponge effect.
If you are starting a maintenance drip, you must use ideal body weight. If you run a fentanyl drip calculated on total body weight, that drug rapidly accumulates in the massive adipose stores. It acts like a giant depot.
So when you finally turn the IV pump off,
The drug just keeps leaching back into the bloodstream out of the fat for days. The patient will not wake up. You needlessly prolong their mechanical ventilation and their ICU stay.
maintenance strips equal ideal body weight.
Okay.
Okay, let's talk about how we're actually giving these drugs. Vascular access. You can't see the veins, you can't feel them.
It's a total nightmare. Blind sticking has an abysmal success rate. You have to grab the ultrasound immediately.
But even with ultrasound, the source nuts, the equipment itself is the problem.
It is. Standard folk catheters are only about 3 to 4.5 centimeters long. In a morbidly obese arm, the basilic vein might be 3 centimeters deep.
So by the time you hit the vein, you have maybe a millimeter of plastic actually inside the vessel.
Right. And the second the patient bends their arm, it pulls out and infiltrates your vasopressors into the tissue.
The text gives a brilliant hack for this. The rule of 3 Pearl.
Yes. Use a pediatric central venous catheter for peripheral access.
A pediatric central line.
Exactly. A pediatric central line is typically 8 to 12 centimeters long. You place it peripherally in the basilic or brachial vein in the upper arm using ultrasound.
That makes so much sense.
It's long enough to stay securely in the vein, it handles high flow rates, and it saves you from trying to place a traditional central line in a neck that has 0 palpable landmarks.
And speaking of central lines, there is a massive red flag in the text about the femoral site.
Do not place a femoral line in these patients. In someone with a large overhanging abdominal pannus, the groin is essentially a warm, moist bacterial swamp.
It's an infection waiting to happen.
The rates of central line-associated bloodstream infections and deep vein thromboses are astronomical. Go for the arm or use the internal jugular with ultrasound if you absolutely must, but stay out of the groin.
Okay, we are at part 4, the critical procedures. If you only remember one section of this deep dive for your shift tomorrow, let it be this one, the airway.
This is without a doubt the most stressful event in emergency medicine. We talked about their total lack of physiological reserve. When you push those induction meds and they stop breathing,
Their oxygen saturation just plummets.
we call it rapid desaturation. You do not have the typical 3 to 4 minutes of safe apnea time. You have seconds.
And the single biggest mistake people make comes down to positioning.
Positioning is everything. The absolute worst thing you can do is lay a morbidly obese patient flat on their back to intubate them.
Supine is deadly here. Let's break down the physics of why.
Look at the anatomy. You have massive adipose weight on the anterior chest wall, and you have huge abdominal contents pushing forcefully up against the diaphragm.
So when you lay them flat,
Gravity pulls all of that mass directly down onto the lungs, physically squeezes the air out of the alveoli. It drops their functional residual capacity, their oxygen storage tank, to almost 0.
you are literally suffocating them before you even pick up the laryngoscope.
Exactly.
So the PBEM next best step is ramping.
Ramping is completely non-negotiable. You must elevate the patient's upper body and head until the external auditory meatus, the ear hole, is horizontally aligned with the sternal notch.
So they're practically sitting up.
It looks that way, yeah. You stack blankets under the torso and head, or you use a specialized ramp pillow, or you drop the foot of the bed into a reverse Trendelenburg.
And that shifts the physics in our favor.
It lets gravity pull the abdominal weight down toward the feet, freeing up the diaphragm so the lungs can expand. And crucially, it aligns the oral, pharyngeal, and laryngeal axes so you can actually see the vocal cords.
The text also stresses keeping them upright during pre-oxygenation.
Yes. Keep the head of the bed at least 25 degrees while you are pre-oxygenating them with the mask. Do not lay them back until the very last possible second. Or honestly, just intubate them in that ramped position.
What about the physical tools? The text is very prescriptive here.
Video laryngoscopy is the standard of care. Your first attempt is your best attempt, so use the camera. And always, always load the tube on a bougie.
The gum elastic bougie. Why is that specific device so critical here?
Because even with a video screen, maneuvering a floppy endotracheal tube through the heavy, redundant tissue of the upper airway is incredibly difficult.
As it bends and deflects.
Right. But the bougie is firm, it's slim, and it has that angled tip. It lets you tactilely feel the tracheal rings as you advance it. It is your ultimate rescue device. If you don't have a bougie opened and ready, you are not ready to push paralytics.
Clear, actionable rules. Ramp the patient, ear to sternal notch, use a video scope, use a bougie.
It will save lives.
All right, to wrap up the clinical portion, let's briefly touch on trauma. Because the text introduces this paradox called the cushion effect. It sounds like a good thing.
It's highly deceptive. In very low-energy trauma, say, a simple fall from standing or getting kicked, the adipose tissue does act like padding. It can actually protect solid organs like the liver and spleen from lacerations.
So the fat just absorbs the blow.
In minor trauma, yes. But, and this is a massive clinical pitfall in high-velocity trauma, like a motor vehicle collision, morbid obesity increases mortality by 1.5 times. The cushion completely fails.
Why does it flip like that?
It's pure physics. Kinetic energy equals 1/2 mass times velocity squared. A much heavier body generates a massive amount of kinetic energy moving forward in a crash.
So the deceleration forces are just huge.
Think of the fat layer like bubble wrap. If I punch it, the wrap protects what's inside. But if I smash it with a sledgehammer, the bubble wrap bottoms out instantly, and that massive kinetic energy transfers directly into the skeleton and the organs underneath.
So relying on that cushion gives you a false sense of security.
Completely. These patients have significantly higher rates of rib fractures, severe pelvic fractures, and pulmonary contusions because their own mass works against them. Do not let the lack of external bruising on that thick, soft tissue fool you. The internal damage is massive.
Okay, we've covered a huge amount of ground. Let's synthesize this into the PBEM Edge, the final board review takeaways. If you are a resident standing in the resuscitation bay right now, what are the top 3 non-negotiable rules?
Rule number 1, airway positioning. Never intubate these patients flat. Ramp them until the ear aligns with the sternal notch. That is the single most effective intervention to prevent a hypoxic cardiac arrest.
Perfect. Rule number 2.
Dosing strategy. You must know your pharmacology solubility. Succinylcholine and rocuronium require total body weight. Propofol and maintenance sedatives require ideal body weight. Do not mix those up.
And rule number 3.
Diagnostic vigilance. Do not trust a low BNP in a dyspneic patient. Do not trust a standard blood pressure cuff on a large arm. Assume their baseline physiology is actively masking a lethal pathology.
It really fundamentally redefines how we evaluate these patients. And I think the most profound takeaway for me today is redefining the concept of stability.
And that's exactly the final provocative thought I want to leave you with.
Yeah.
In emergency medicine, we rely so heavily on the word stable. Patient looks stable, vitals are stable.
Right.
But when you look at the patient with morbid obesity, knowing they have zero respiratory reserve, knowing their cardiac failure might be masked, knowing their drug metabolism is altered, you have to ask yourself, is this patient ever truly stable?
Or are they just balancing on a much thinner wire than we can see?
Exactly. For them, a minor physiological insult requires a major resuscitation mindset from the physician. Treat the altered physiology, not just the chief complaint.
Incredible advice. Thank you for walking us through this minefield today. For everyone listening, make sure you check the show notes for the Crandall formula calculation and that critical medication dosing cheat sheet. This has been the ED Debrief Deep Dive into Chapter 298. Keep studying, stay safe on your shifts, and we'll see you in the next one.
Keep your ramp handy.